Are they working? Can you hear me? Thank you. Although it's, I guess, still 2 minutes when we should be starting, but since we have a house full of these speakers, all of them have been here, and I am so, so glad that they have all made for this session, and so grateful to all these speakers and panelists here. Likely to share knowledge with all those who were at home and they couldn't actually go out for learning, and the conferences were not happening at that time. Apart from the basic sessions, we also did mentor and mentee, wherein the mentees were presenting their surgery sessions, and it was the mentors who were giving comments and trying to guide these mentees. This was the kind of group it was when we started off. We had about 1,000 members joining in the first year itself. We started from 200 people, and we went on to have 1,000 people. It was in 2021 that we started making our collaborations world over with all the other ophthalmic societies globally, which had a similar kind of passion for teaching, training. And it was at that time that the Global Summit in 2021 was the first summit we did. And in this summit, we had almost a very, very rich panel here. You can see the photographs. All of them have huge amount of work behind them. They had been invited as speakers. We had a 3-day program. And since then, we haven't stopped. And it was all because of the energy which was given by the attendees which were attending and all the emails that we received. In 2022, we again did our Global Summit 2. And again, we had a great attendance. Since then, in about 2022, we kind of evolved ourselves from not just being a learners group, but into a research forum as well. And now at these research forum is the basic, the mission and vision of this research forum is to try and bring people globally together who would have similar kind of a passion to bring about those studies which would have global impact. And now I'm so glad to say that we have brought about a lot of basic scientists who work on endothelium as well together. And this is what in 2024 the forum looked like. You have a lot of basic scientists also who have joined us. Since then, I would stop the slides here. I'm not showing those slides wherein we have also come out now with the publication of our first Delphi. The first Delphi was totally focused on seeing that what are the ways in which EK outcomes can be improved, and that's already in print, and we are about to go ahead with our second Delphi also. With this introduction of EKLG, and as we have the attendees joining us, we would be beginning with our first talk, and I'll hand over to Professor Bruce Allen.
Great. I hope this microphone is live and you hear me all right. Well, Nidhi, I do admire your energy in getting all this together. It's absolutely fantastic. And so for the first talk in the program, I'm going to call on Dr. Sunita Charasia. And we're going to hear about Rho kinase inhibitors.
Thank you, Yeah. So Rho kinase inhibitors, and these are for basic researchers as well as clinicians, can be one type of enigmatic molecule. So my talk is on Rho kinase inhibitors. Are we close to clinical application? Now, when we talk about Rho kinase, it is important to know that ROCK pathways are existing in the corneal endothelium, and these are the pathways which control several of the cellular functions. The activation of ROCK pathway in corneal endothelial cells is paramount in the pathogenesis of corneal endothelial dysfunction. ROCK inhibitors, when we use, they target the ROCK pathways by inhibiting the enzymatic activity of the two ROCK isoforms, ROCK1 and ROCK2, and hence their application in endothelial dystrophies, endothelial injury, and post-operative endothelial cell regeneration. If we look into the various kind of ROCK inhibitors, the chemical structure wise, there are 4 different types of ROCK inhibitors, the Y27632, which was the first initial molecule, and then fasudil, ripasudil, and nitarsudil. Of these, the interest is in 2 molecules, which are ripasudil and nitarsudil. So ripasudil is available as Glanatec 0.4% in Japan and Ripatec as 0.4% in India. Nitarsudil as Ropressa in the US and Netalo in India. So application-wise, if you look at the various studies which have used these Rho kinase inhibitors in Fuchs endothelial dystrophy, there are majorly about the clinical study with good sample size, good number of patients, 3 or 4, majority are with very small sample size of case reports and all. So there are 2 studies, I'll name it over here, and these are the ones which they have tested the ripasudil along with DSO in 2 studies with sample size of 23 patients and 18 patients. And nitazoxanide has been used per se as a standalone therapy in some cases in one study with good number sample size of 29 patients. In pseudophakic corneal edema, this was the landmark paper from Professor Kinoshita. It was used in 11 patients, and we had good results with that. So if you look into summarize into the applications of Rho kinase inhibitors, what we have currently as evidence is as standalone therapy in endothelial diseases, there are very few, and is majorly used as conjunction with other therapies and procedures, mainly with DSO and with cultured endothelial cells. Evidences supporting efficacy, standalone-wise in Fuchs, there are few studies. One is by Price et al., which was testing nitazoxanide application in 29 patients. And then we had some patients where it was used in, this is just a case report, in IC syndrome, and special situations where it was used for cases which had a low cell density, and these was 4 patients in that study. Looking into the safety consideration ROCK inhibitors, the data has come from the glaucoma trials, and we know that 94% had adverse events, majority of which range from conjunctival hyperemia in majority, from blepharitis to allergic conjunctivitis, and eye irritation. Safety consideration for nitazoxanide has come from the Rocket 1, 2, 3, phase 3 clinical trials, again from glaucoma studies and Mercury trials. So where nitazoxanide was used once daily and compared with timolol, again the same spectrum of side effect profile was conjunctival hyperemia, cornea verticillata, and conjunctival hemorrhage. So overall, not very severe symptoms, but then conjunctival hyperemia remains a major side effect pertaining to Rho kinase inhibitors. I'll just share some of my personal experiences where I've used in some clinical situations, such as Fuchs endothelial corneal dystrophy, where there was evidence of subclinical edema and early morning symptoms. I have also used for pseudophakic corneal edema and cases where you have low cell density, like grafts with low endothelial cell density and requiring cataract surgery, post-graft rejection in the resolving phase, and I'll just put a perspective of what it does in the normal healthy eyes. So in FECD and pseudophakic corneal edema, there's a variable response which I've experienced. Some patients do have a response, some patients are equivocal, and some patients just don't tolerate the medication. So these are some of the representative cases. I'll share this one case. This was a patient who came in Jan 2022, and she was already using Ripasudil twice per day. She was quite fine with that. And December 2022, she stopped using Ripasudil altogether. And these are the OCT images and the specular images. The E and G are from the center part of the cornea of the right and the left eye respectively, and F and H are from the superior part of the cornea. You can see the endothelial morphology in F and H, but in the center part, as is well known with Fuchs, will not be able to capture the endothelial cells. So she was quite okay with that. And 1 month later, when she stopped the medication, this is how she landed up with. She came with obvious edema, increased symptoms, and she was not able to procure Ripasudil, and that is why she had stopped it. And we can see that the epithelial, the OCT shows the epithelial edema bullae in both the eyes. Subsequently, we did start her on, she procured the medication, and this is how the edema resolved subsequently, and she has been on follow-up. And in her last visit in December 2024, she has been maintaining good vision, decent vision, and has been living with this routine of using Ripasudil twice per day, and has been asymptomatic so far. This is another case who was a professor. His requirements was that he wanted to have some medical therapy in 2018. He came with symptoms of intermittent blurred vision and was using hypertonic saline. And that time, Ripasudil was not available in India. 2022 onwards, we started Ripasudil along with hypertonic saline on SOS basis, and he is stable till Jan 2025. So he's been asymptomatic and managing his routine well. So again, the same thing, the top picture shows a specular microscopy from the center part of the cornea, where we cannot procure the images, but the peripheral cornea shows a good amount of endothelial cells. This is one case of pseudophakic corneal edema with a sectoral nature. It is partly involving the center area. And as we see in the first picture, the image has been captured from the mid-peripheral location. In the subsequent, when the medication was started, this is how he has been. And the patient, the second image is a specular image from the center part of the cornea. And thereafter, the patient has been stable since 2020. Now, why 2020? Because this is a time point when this medication was available, and that was a time when there was no corneal tissue, and that is why we had to look for alternatives, and that is how most of these patients are from 2020 and 2021. This is another case 4, where we saw this patient in 2020 again, 8 years post-PK, and she was having a partially functioning graft. This patient is stable without worsening of symptoms till last visit in December last year. So she was again put on the same medication. As of now, she's okay. So this is another case, case 5, where PK was done for keratoconus, and the patient 6 months later landed up with a rejection episode. The duration was of 3 weeks duration, 3 to 4 weeks. IVMP was given. She had persistent edema with 6 weeks of treatment. Now, generally speaking, when we see a severe graft rejection with a 3 to 4 weeks symptoms and without any therapy, we will expect that graft to sort of fail. But this particular case resolved after there were 6 weeks of persistent edema. Subsequently, there's a good recovery seen in April 2022. And thereafter, in October 2023, this is how the picture is in the last visit, 2024 October. And last visit, she's doing well with a good maintained vision 2040. We can always say that this was a case of keratoconus. Probably there was something to do with the redistribution of the endothelial cells, which could have accounted for a good recovery in this particular case. Now, this was one case, and again, this was one study which we undertook in normal, healthy volunteers during the same time period when 2021, where we wanted to look at the molecule was available in India. It had got the DCJ approval, and we wanted to see what it does to the normal endothelium in normal, healthy volunteers. So we did see that there's a pattern which gets altered. This is a normal morphology. And when you see the second image, there's a dark light reversal pattern, something similar to what you see with the eye syndrome, which subsequently gets altered to back to normal in 3 to 4 hours. Now, the implication of this is that if you have to image any patient, any person who is on Rho kinase inhibitors, we have to ensure that the specular microscopy is done 3 to 4 hours later. Otherwise, we'll get a fallacious count. So this is what we did, and this was kind of consistent in every patient, every 14 healthy volunteers, which we saw in that time period. To summarize the current status, we certainly see that there's a positive outcome in corneal endothelial diseases with Rho kinase inhibitors. However, there's a variability in responses. Some limitations remain, longer duration of effect compared to surgical management like DMEC. We don't know, there is a time point where we have a certain limitation because it may not be very active immediately compared to DMEC surgery. It may be ineffective in advanced stages of disease when endothelial cells are not healthy at all and when peripheral cells are not adequate. And this might lead to rhapsodial or Rho kinase-related corneal edema, which is well described as honeycomb edema. Long-term outcomes with larger sample size is required to really know what is the outcome, which at this point is missing. And we also don't know, we know that it works very well with DSO in FECD cases, but how effective it is when CEC layer is intact is not certain. And what is the optimal frequency of medication, again, is not very certain. So we do need further investigations on standalone therapy before standard guidelines can be established for its use. Thank you very much for your patient listening.
We have a moment for questions, and since we have Professor Kinoshita sitting on my right over there, I'm going to ask you
yes.
to comment.
Well, thank you very much. And Sunita, that was very nice, I think, a very nice presentation. Although we know some of if the endothelial defect and it's kind of an acute injury of the endothelial defect, at that time, Rho kinase inhibitor is effective. That is based upon the animal experiments and also human experiments. And now the DSO with some of the eye drops of the Rho kinase inhibitor, rhapsodial, that was, I think, a clinical trial, phase 2 was performed in the US, and that was successful also. So we understand that. But for instance, Fuchs endothelial dystrophy without any endothelial defect, whether the Rho kinase inhibitor is effective, you said that is still the kind of positive but questionable. So I think we really need some kind of a double-blind clinical study or something like that. But your data is quite suggestive. It's a positive. So I'm at least in my personal opinion, very happy to hear that. Thank you.
I have a question for all the panel here that when we are using Rhapsodial, what would be the correct parameter to actually see if it's actually, having an impact on the endothelium, whether it is actually the count or it is going to be the CV in the specular? Is it going to be the exact count?
Well, I think at least hopefully endothelial cell density, increased endothelial cell density, or before that time, if you couldn't see the endothelial cell, and then that could seen after the treatment. I think something like that. But I think Bruce Ra and Friedrich Kruse, they published a very nice paper in in AJO a couple of years ago, taking the DSEC flap and then cutting in half, and then one is treated with low kinase inhibitor in the vitro, and the other is not. And then they performed some of the PCR to see the several important molecules, and then at least, for instance, acroporin 1 is upregulated, or some of the molecules are upregulated. So I think theoretically, conceptually, low kinase inhibitor is I think normalizing the function of the corneal endothelial cell. That's what I thought.
And a question to you both: dose frequency. What would you go for at the moment? Let's say in a DSO case, what would you do?
Personally, for DSO, I don't have not done DSO per se, but I have used in standalone therapy. So in those cases, I have given a dosing of twice per day.
So I think that lasts for at least 6 hours, right? Based upon the one drop single application to
Yes.
the normal subject, and the endothelial cell morphology is
has
changed, and up to 6 hours at least in our hands. So I think that 3 times a day, that is quite reasonable. And also phase 2 clinical trial, they compared double and twice a day and 3 times a day and 4 times a day, I think so. So but 3 times a day is a kind of appropriate, I think, application for that.
I just have one comment here, that we in India see a lot of SICS surgeries that we do, and that causes a lot of endothelial cell loss post-op, especially if they have been hard cataracts to remove. And in that interim period, when we have edema, that was the time when I thought maybe Rho kinase inhibitors could be a solution and not straight away go for a transplant. And in them, using it 4 times for about a period of 6 weeks has helped the patient recover. And one more observation that I had, because I was very inquisitive to understand whether it is going to be the specular count or what parameter, then I found that the CV of all these patients were increased when I was giving a Rho kinase for that period of time. So that is just an observation. I really do not have a study for now, but that was something very interesting I thought I wanted to share with everyone.
Yeah, thank you very much. And especially at the time, just after the cataract surgery, and if you think they had some of the injury to the endothelial, so definitely I think low kinase inhibitor is a choice for the in addition to the other treatment as well.
Good. Well, Nidhi, we should move on with you, I think. That's using young donors for DMEC.
Between the two, ripacitil and letrozole is useless just because of the side effect or the efficacy?
So both, so that netasodil has a dual mechanism. So that's the one of the things which is different between both the things. But clinical application-wise, not noticed much of difference between the two. But yes, I've used more of ripacitil compared to netasodil because that came first.
Great. Thank you very much. Nidhi, please.
I have a question.
Well, I think we're going to have to move the session on, I'm afraid. And if we have time at the end, we'll do some more discussion, okay?
Yeah.
Yeah, we'll take your question towards the end. So I will be talking about using young donors for DMEC. We know that we have evolved over time, and DMEC has provided faster, complete visual rehabilitation and reduced the rate of immune reaction compared to DSEC. However, what has remained unresolved is the intracameral unfolding, which is little less standardized. Most of the critical steps and mechanical manipulations during this time is when we have the cell loss, which is about 35% cell loss in these patients have been reported. It is primarily because of the tightness of the scroll is more in the younger donors as compared to the older donors, that despite of the better endothelial cell count, we have still restricted ourselves to the use of the older donors. Hence, most of the eye banks prefer high donor age with higher endothelial cell count. Now, what has happened over time, and I'm glad John Batchman is here, right here, and there is some work which even they have published wherein they have used very young donors. There are also reports that, the temperature variations in the fluid in which the DMEC remains stored causes a difference in the scroll size, the tightness of the scroll of the DMEC tissue. Now, we had some key questions in front of us when we were trying to actually use the young donor DMEC tissues with higher endothelial cell count, because that's a large majority of tissue we get in the eye bank, and also using the tight scrolls was to answer these basic 3 questions. that why does the DMEC graft scroll? Why does the DMEC graft scroll always towards the endothelial side out? And why there is a difference in the young versus the old DMEC graft to scroll. So there is a work wherein you know that the composition difference is there between the infant and the adult human basement membrane. That is that if you compare the young donor DMEC tissue versus the older donor tissue, the anterior banded zone remains constant. That is after birth, that is the zone which remains always 3 micron. But it is the posterior non-banded zone which is secreted by the endothelial cells which keeps accumulating and causes a difference in the thickness of the tissue in the young versus the old. Now, the anterior banded zone is composed of collagen 8, whereas the posterior non-banded zone is collagen 4. Hence, there is a difference in the ratio of the collagen 8 versus collagen 4 in the young versus the older tissue. Also, we know by this remarkable work by Professor Dua, who had actually gone ahead and studied the DMEC tissue, and he found that the elastin was lining the inner lining of the DMEC tissue. And he actually hypothesized that it is the elastin tissue which lines and causes the scrolling of the DMEC tissue always on the endothelium lying on the outside. And this is what is different in the PDEC tissue, wherein you have the collagen on both the sides, and that's why it doesn't scroll as much as the DMEC tissue. That was a theory that he had given. However, when we went ahead and we tried to dry up the DMEC tissue and observe it, we found that the DMEC scroll did not happen. It did not happen when it is get dried up. So this is the question. If elastin was the only reason by which the DMEC was going to scroll, why it was not getting scrolled when it was without a fluid? We went ahead, we put in these experiments with Indian Institute of Technology in India, and this is the team who has worked up for these experiments. What they had done was to dry this tissue and then actually put fluid and see that the scrolling behavior only happened when the tissue was inside a fluid. It would never happen when it was without a fluid and air dried. They went ahead, they actually created this apparatus wherein they could photograph each DMEC tissue that we had provided them. They also created an analog with the chitin tissue, exactly like the DMEC tissue, and they measured the scrolling property of the DMEC tissue in the young versus the old tissue. What you see in the graph here is not only the amount of the scrolling, it is also the time period which the scrolling takes time. And what they found was that the DMEC tissue not only scrolled differently in the young versus old, it also was different when different fluids were added to it. You can see in the graph on the right that sodium chloride versus dextrose versus glycerol, all three scrolled this tissue in the different amount. The amount of scrolling was different. And they hypothesized this, that it is the diffusion coupled deformation phenomena that actually causes the DMEC tissue to scroll. And I'll just explain that the DMEC tissue, if you see, is different in the anterior versus the posterior part in composition. So the fluid gradient across the DMEC tissue is different in the anterior versus the posterior part. And this is this concentration gradient across the film thickness that results in displacement of the fluid and different bending of the anterior versus the posterior banded zone. Hence, the DMEC tissue, if you see, is actually the inner layer is scrolling lesser than the outer layer, expanding lesser. That's why the scrolling happens. These actuation characteristics are governed by the stiffness, the geometry of the film, and the diffusion characteristics of the solvent. And it was very interesting to see that it was not only that the difference in the fluid, but also the fluid composition differences in the percentage of the fluid composition differences caused a difference in the scrolling time of these tissues. Hence, we came up with this paper we had published with that group, wherein we showed that it is actually the diffusion coupled deformation phenomena which causes the DMEC tissue to scroll. Now, while we were doing this experiment, this is something for the clinicians, we kind of came up with some steps for preparing this tissue, and this is the technique that we came up. If you look at this, this is the double refined technique that we used in all 40 patients of the young DMEC tissue, which is 40 years and below DMEC tissue that we prepared. These are the usual steps, but there is one step which I would like to definitely share with everyone, was that if you see the separation of the tissue in the young DMEC tissue, there are too many adhesions of the Descemet's membrane to the underlying stroma. Hence, it is advised that when you're doing these separations, unlike in the adult tissue, wherein you can actually go beyond 1 mm inside the tissue while dissecting, in this you need to stay in the periphery all 360 degree until you have separated and broken all the adhesions. You can see the adhesions are so strong here. The second tip would be, you can see my left hand holding wherein very closely I'm trying to dissect. It has to be very close and sometimes almost peeling the Descemet's membrane when trying to break this, trying to separate the DMEC tissue. I would go ahead with these diagrams to which explains it better. And the third tip, which will be that when you're trying to pull in this Descemet's membrane in the young tissue, the force has to be tangential and not central. Unlike in the adult tissue, we try to pull the DMEC tissue towards the center. The force has to be all in the periphery tangential until, like you can see the diagram 8, that explains it very well. That's how, if you are going to have a force, you can have very good DMEC tissue. This is unpublished data. We are still writing this study wherein we actually did 40 such tissues below 40 years of age. And we were successful in preparing about 76% of the grafts were prepared by this technique. We were able to actually dissect off very young tissue. Now, the second question that comes in using a young tissue for DMEC is how you're going to unscroll it. Then a very nice technique, that is Depina's maneuver, has been described wherein an air bubble can be kept on the top of the DMEC scroll, and that air bubble can be used to give gentle strokes to open up the DMEC tissue. We haven't done many clinical patients, but this is one of the patients of Fuchs dystrophy wherein a very young 36-year-old tissue was used, and we were able to get successful outcome in terms of graft preparation, as well as the post-op follow-up has been great with this patient. The endothelial cell count has been very comparative to what you get in adult DMEC tissue. So with this, I would just like to summarize my talk by saying that there is a difference in the scrolling property of the young versus the old DMEC grafts. The physics which explains the difference in the scrolling property is the diffusion-coupled deformation phenomena. That is what we are proposing. The graft preparation requires a different technique with modifications. We were able to get about 70% chances of success with a young tissue, less than 40 years of age. And we agree that endothelial cell loss and longevity of the young DMEC tissue, we still need to test it in a larger cohort. With this, I would like to end my talk. Thank you for your attention.
Nidhi, that's lovely. We'll have to move on quite quickly to keep the session on time, but I will ask you one question that you can answer while you're sitting down. I'll come up to the podium. That is, how young is too young? Is there a lower limit for you?
Yes, I guess the youngest that we have done is about 26-year-old. But I quoted Professor John's paper wherein at least 17-year-old has also been dissected off in papers. So if you have a comment to say.
Yeah, so we try to use patient or donors at the age between 40 and 70 years. That's our normal range. So this happened by accident to use such a young donor, and I wouldn't recommend it for normal cases. However, I find it quite beneficial if you have younger donors with tighter scrolls, if you have a more shallow anterior chamber, because in those situations, if you have an old donor which almost doesn't scroll, it's not easy to turn it around if it's an old donor. So in some situations, it's more beneficial to have younger donors than older donors.
Good, that's great. And so coming on to something a bit more on the learner side than on the research group side of the thing. And so I think it would be more interesting. We've got some very good talks coming later on the research side. And so if we can maybe do the discussion for anything. My talk, I'm happy to stay behind afterwards and talk to you about tips and tricks. So this is some things that may help you in getting over some of the difficulties with DMEC. And what I would say is watch a lot of video. Every surgeon has something good from their technique that they can steal from your own, okay? There are lots of different ways of doing it, and here are some things that have helped me. Even if you find one thing that helps you, then it's good, okay? So here's preparation, a bit different from the technique that Nidhi just showed us here. We score inside the, a little bit more central to the trabecular mesh work. And what we're aiming to do here is get a nice continuous score with no tags or breaks. And think of an old-fashioned record player with a vinyl. You're moving the graft and you're keeping your right hand on the Sinski hook, nice and stable. And the main message is it's a light touch. Don't press down too hard. Don't get stuck in the stroma. Then you get a nice continuous score. And then when you do the peel, you don't get tears. Okay, so aim for a light touch and a continuous score. And then on the host side, it's exactly the same thing. It's a light touch and a continuous score. You're trying to stay out of of the predecimase layer here and not roughen up the stroma, because one of the things you want in DMEC is what I call a clean landing zone. So it's completely opposite of what we used to do with DSEC, or we used to deliberately roughen the periphery to help the graft stick. You want a clean landing zone. And it's, again, a really light touch, and then just encouraging the edges in before you fold it in. And there's a particular movement to encouraging the edges in, and it's not a radial pull. You don't pull straight into the center. You move, it's a bit like this. It's, can you see a sort of a tangential sweep there? A bit like what I call the Nike sign, you know? You're going along and then you're just teasing in at the end, all right? We're just going to show you that here in slow motion. So going along and then just teasing in a little bit, okay? So it's not a big pull, otherwise you're going to get a tear again. And so, can you see that? That's the Nike swoosh, if you like, all right? But make of that what you like. But don't just pull radially. When you're preparing your donor, leave your trolley with the donor, everything ready. So when you've done your preparation on the host side, you already have everything there. You don't have the nursing team, the patients, the live surgery video photographers outside waiting for you. It's all done, okay? You have the trolley nicely laid out. So do be tidy on your donor trolley when you finish the preparation. Leave everything ready. And then when you're ready to stain, just, you know, dry out a little bit. And my main technique, my main tip for this is to say use dual membrane blue. So not just trypan blue, the dual blue stains that the retinal surgeons use, they give you a much more longer lasting stain. So if you have a difficult case, difficult visualization, then you don't lose the visualization. So fill the cup up, and then when you're tipping this into the donor side, you just kind of pull the stand out from underneath it, and you can put it into what I call the swimming pool there. That's just BSS that you've prepared. And then with your glass cannula system, this is the goiter system, but most of the systems are very similar. You can turn it around until the graft is in the right orientation for you. Hold on the end of the glass so you can see where the donor is as you suck it up into the narrow portion of the injector. And then you attach to get a closed system. You don't want any air bubbles in the system at this stage, otherwise the endothelial graft will stick to the glass, and that's bad for the endothelium. And so then you can fine-tune the position before you detach the tubing to put the graft just where you want it in the thin portion of the tube, ready to inject. And then carefully unscrew that, again under direct vision under the microscope. Then you're ready to inject. And what I would say there is use some kind of irrigation to maintain the chambers, so you enter the chamber nice and atraumatically in a deep chamber, and a little bit of twisting there to get in through your entry site nice and easily. And once you've got the glass cannula in, come round, and here's a really good tip for you. If you're using a plastic syringe to inject, don't hold the end of the plunger, just hold the plunger as it goes into the barrel of the syringe, and then you can kind of feel it in. It gives you a lovely control on a slow injection. If you put your thumb on the end and just press, it sticks and then it comes out too quickly, okay? You don't have any control. And then you can rotate it into the right orientation as the graft goes in, inject slowly, modulate the depth of the AC before you complete the injection there. Let's see that from inside the eye, just here. So you've got the chamber maintained. We do in a combined case our cataract surgery just like we normally would, with no compromises on pupil dilation, and we just leave the pupil dilated if it's well dilated, no PI, and then inject as slowly as you can, watching the back of the graft, watching the orientation, but a slow movement if you can. And you may think, well, look, this is going to be bad for the endothelium if you're doing it without a meiosis of the pupil. We didn't find that when we looked at that. We haven't had a problem with the cell counts afterwards. And so just a real slow injection, leaving the graft the right way up, coming out of the chamber carefully, and then you're ready for your mini bubble. And if you want to open a scroll up, this is another case, just tap on the end. If it's an older donor, you'll have no trouble getting it to a double scroll, and then you can open it out a bit more if you want to. Mini bubble DMEC, this is something that Frank Price showed me, which I really like. And this is so you can work away from the lens in a deep chamber. As soon as you get any kind of open conformation of the graft, it doesn't have to be completely open at all, then you can just put a small bubble underneath it. And it needs to be about the same size as your entry site, the bubble. Put it under the graft, And it doesn't really matter, where the graft is. You just trap it against the cornea like that, and then you can use this sweeping technique to center the graft, and the graft will often unfold when you do that. And if the bubble escapes and it doesn't unfold, then you can easily just do that second step again. And then you're ready to fill up the chamber to a good pressure and use your air exchange paracentesis, a little vertical one there, to fill the eye to a good pressure, and that helps the graft to stick. So that's mini bubble DMEC. How about a younger case, the kind of donor that Nidhi was showing us just now? This is the worst combination, a younger donor in a vitrectomized eye, a deep eye, and you'll see that it doesn't matter how many times you try and open it in a double scroll conformation, it won't be stable. So you can use the bubble on top technique. There are lots of different variations to try and help you open it, but the problem that we've had sometimes is keeping a stable conformation. And so you'll see here, it doesn't matter what you do, as soon as you take the instruments off, it wants to scroll up again. So what can you do? Well, you can just work on one end of it, just like we showed you before, just tapping one end until it folds into a triangular conformation. And that is stable, unlike a double scroll. And then you're ready for your mini bubble. Let's just see that now. So you're tapping just on one end, and I'm sorry, this is not great video because it's not very well centered, but I think you can see the triangle there, ready for the mini bubble underneath it, and just get a bubble underneath it, and as soon as you're pinned against the cornea, you have one, okay? And then you can open the graft out. And you can just use the tapping over the top to open the graft out, and usually the graft will open up the rest of the way. If the bubble is too large, by the way, the graft sticks to the cornea and you can't open it, so it has to be a small bubble to make this work. And that's just finishing off there. And then last word on how you exchange the air bubble at the end of the operation. It's nice to do this a bit like the vitreoretinal surgeons exchange their gas, but to try not to collapse the anterior chamber, because after you've filled the eye to a high pressure to stick the graft, I always tell the patients it's like sticking a postage stamp to an envelope. It's a bit like the records, that the older people will understand that, but not the younger people. Nobody posts with stamps anymore. But you're sticking on with that pressure, and then you want to not detach, break all those weak secondary bonds that hold the graft in place. They stick in the same way as paint sticks to a wall. It's with weak secondary bonds, lots of them. You need to get the fluid out from the interface to keep it there. And if you don't exchange the gas carefully, if you just collapse the chamber, then you break all those bonds. So it's exchanging in one paracentesis and letting air out from the other. And you keep going until you're sure the bubble is detached from the pupil if you're not doing a PI, and if you're doing a PI until the bubble is clear of your PI. So I'm going to try and put these tips up on YouTube when I get time. There's some other stuff up there. You can easily find it, and I hope some of it's helpful. But I also want to give a brief advert, if you like, sorry Nidhi, for our little congress in Prague, EU Cornea. If you want to join the Europeans, the corneal surgeons there, it's a fun meeting. It's all corneal surgery, a good mix of science and clinical technique, and we usually try and have it in a fun place like Delhi. And this year it's in Prague, and I do hope that some of you are able to join us there in June. Nidhi, thanks very much.
Thank you. Have a comment?
Shall we go straight on? I'm happy to stay afterwards if everyone has any questions for my talk, okay?
Have some time for questions, because this is probably the last session of the day in this hall. So if you have any questions for Professor Allen.
Oh, okay.
Yeah, so wonderful videos, Professor Allen. I didn't see any of the patients you use any marking in your graphs. So you're done away with that, or?
I don't, and but I don't want to say that what I'm doing by not marking is right. It's wrong, okay? And for if you're in a learner group, I suggest you do mark anything that helps you, okay? But in terms of if you do enough DMEC, you can see which way up the graft is without a mark, right? And so when you're confident about that, then you don't need the marks anymore. And similarly on the sizing of the rexus, you kind of know. And but as I say, in terms of the right method to do the technique, yes, you should mark, and yes, you should do everything that keeps your technique the same in every, well controlled. But I think that when you get confident and you've done a lot of cases, you will be comfortable to not mark anymore,
Yes, so congratulations. Very elegant techniques you showed here on your videos. Very impressed. So do you match the donor age with the situation of the anterior chamber? Because you showed this case of this very young donor in vitrectomized eye, or you have the chance also to ask the eye bank to get donors of certain ages?
Yeah, again, I feel embarrassed because the question implies a level of control over what we are getting in tissue that we just don't have. And we ask, and yes, we have some limits on the donor age, and that's why I was asking how young do you go. But at the moment, I'm afraid in the UK we are short of material, and we operate with what we have, is the answer.
I guess, are there any audience questions, or we can go ahead with the next talk, I guess. Thank you, Professor Allen. You want to announce that?
Please go ahead, I think.
Yeah. So it's a pleasure and honor to have Professor John Matchman all the way from Germany. Thank you for coming for us, and he will be talking about EndoArt. I guess that's the next thing we want to hear from you.
Yeah, so thank you for inviting me. It's a real pleasure to be here. It's a great congress. And yeah, so we heard a lot about DMEC, and my topic is about EndoArt. Still, I want to start with DMEC. So I want to start because DMEC is not only beneficial in terms of better quality after transplantation, in terms of visual acuity for the patient, but also we see much less graft rejections after DMEC compared to all other transplantation techniques we had before the introduction of DMEC. So this is our cohort from Cologne, where we showed that we have a graft rejection rate of 2.3% after 4 years, and the average duration until the rejection took place in our patient group was 9.9 months. So we barely see coated-off lines, as you can see here in this example after DMEC. This is very, very rare, and if you see this, this is typically at the periphery of the graft. So can you see my mouse here? No.
Mouse for the
Here,
speakers?
I think
Yeah,
I made it. Okay, great. So you can see the coated line here, typically at the periphery of the graft. Usually if you see rejections, you will see deposits all over the graft or at certain areas of the graft, but not as a line typically. Again, here this is an example of a coated line, and here it became worse first, and then after treatment the cornea cleared up again. So this is a good message about rejections in DMEC. Many of those cases, if you treat them aggressively with steroids, you will convert them into normal dehydrated corneas again. So, but as you can see here in this example, this is not a regular Fuchs patient. So this is a patient who had different surgeries before with scar formation here, the neck here, and so on. So these are patients which are at higher risk for developing a graft rejection after DMEC. And there's two papers which describe the influence of the blood-aqueous barrier by measuring the flare before and after transplantation. And this is one paper from my colleague from a different university hospital in Germany, Lami Baidoun. She published in 2018 her DMEC cases, where she showed that higher postoperative flare after DMEC in the early phase was also associated with graft rejections later on. And this was also something which was published in a PK group some years before already. So they also found that higher postoperative flare was associated with later rejection. So this comes to the thesis that the disruption of the blood-aqueous barrier promotes graft rejection after PK and also after DMEC. So if you look at our cohort of patients from our own university hospital where we perform DMEC, the majority of our patients are Fuchs patients. Then we have around 5% of our patients with Fuchs pseudophakic bullous keratopathy. And then we have a much smaller group of other patients. Less frequent indications are, so let's say, among the group with little patients or with few patients, we have this larger group of patients with glaucoma drainage device or other glaucoma surgeries. And most of those indications, they come with a disruption of the blood-aqueous barrier, and we think that these patients are at a higher risk of having a graft failure and graft rejection after DMEC surgery. And we analyzed our cohort of glaucoma patients, divided them into a group with trabeculectomy and glaucoma drainage device, and one can see that the graft failure rate is very high. So you can find within 2 years around 50% of all those patients with glaucoma drainage device, a graft failure after DMEC. And after trabeculectomy, it's a bit better, but still you have a very high rate of graft rejection and graft failures in this group of glaucoma patients. So and then we had the possibility in Europe 2 years ago almost to use a new device which is called EndoArt. It's what we call a endothelial keratoplastesis, which we started to use in those high-risk patients. The principle is completely different, of course, from the principle you know from DMEC. So there's no active process in pumping out the fluid from the stroma. It passively seals the posterior surface because it's attached to the posterior surface of the cornea, as it's also performed in DMEC with the graft. But it prevents the inflow of fluid into the corneal stroma. It's made of hydrophilic acrylic polymer, so you know this material from IOLs, and it has been CE certified some years ago in Europe, but became available at the market around 2 years ago. The diameter is a bit less than the diameter we typically use for grafts. So in DMEX we use an 8 millimeter diameter. This is only 6.5 millimeter. The thickness is much thicker than a DMEC graft. It's 50 micrometers compared to 15 around in DMEC grafts. And the surgical procedure itself is very easy. As you can see here, you remove the diseased descemet's membrane, and here are certainly no living endothelial cells available in this case. At higher magnification, you will see here a marking down here. It's an F mark, which helps you to keep the orientation during implantation and after implantation. And then it's simply pushing the device with the spatula into the anterior chamber. You can do this under irrigation, and then it unfolds automatically, almost automatically. And even if you then pull it or push it against the posterior surface by an air bubble, and it's not completely well centered, it's easily moved by a hook, till example, to the center. And then at least one fixation suture should be applied, as seen here. And we also close all entrance wounds to really have the wounds tight and to avoid the outflow of gas after the surgery. And so as you can see here, this fixation suture, this is needed because the attachment of the device is much worse than the attachment we know from grafts from DMEC or also from DSEC grafts. This is a clinical example of a patient who had a perforating trauma some decades ago. Then he had cataract surgery, he developed an implantation cyst, and this was excised. This was here in the upper outer quadrant. And then he had a PK, and he also had the implantation of an artificial iris. So this is what we really consider to be a patient at higher risk of graft rejection even after DMEC. So we discussed with the patient the possibility to perform the implantation of the EndoArt device, and as you can see here, once it's attached to the posterior surface, then there is a good dehydration of the cornea, and it gets even low till 433 micrometers in this endothelial decompensation after PK. So we analyzed the cohort, which we also published in 2024, of 44 EndoArt surgeries and 38 glaucoma, of which 38 glaucoma patients were glaucoma patients. 17 of those patients had a glaucoma drainage device. 80 patients had other types of glaucoma surgeries before. 22 patients had previous DMEC surgeries. Many of these patients don't even have just one surgery or two DMECs. Some also had 3 or even 4 DMEC surgeries. And 6 patients had a previous PK. Here another example of a patient with a glaucoma drainage device. And there's a good dehydration if it is attached. This is an improvement in visual acuity, and these are all patients with low expectations in visual acuity, though there is quite an improvement. This is logMAR visual acuity, but the level of these patients is of course very low. But as you can see here, the dehydration of the cornea, or the stabilization of the edema of the cornea, works quite well on average. So the mean preoperative central corneal thickness was almost 800 micrometer, and the average thickness 3 to 4 months after surgery was around 500 micrometers. So the main complication is graft detachment, and the main additional surgery which is needed, of course, is then rebubblings, and we compared we divided the whole cohort into two groups. One group was a group with iris lens diaphragm defects, and the other had an intact iris lens diaphragm. And as shown here, one can see that we needed up to 5 at that time of analysis, 5 rebubblings in the group with iris lens diaphragm, because there's a very rapid displacement in many of those patients of the air bubble from the anterior chamber to the vitreous cavity. And in the group 2, without any defect in the iris lens diaphragm, we also needed rebubblings quite often, but the maximum of rebubblings was only 3 times. So we also add additional holding sutures if we need additional rebubblings. So if a patient receives 2 or 3 or 4 rebubblings, we place at the time of rebubblings also additional holding sutures. And we had here a patient which also needed 6 holding sutures at the end. And here in the group 2, we only needed 3 holding sutures. We also wanted to know the influence of the glaucoma drainage device on the rebubbling rate. And if we divided our cohort into the patients with glaucoma drainage device and those patients without glaucoma drainage device, we found around 50% of the patients with glaucoma drainage device needed a rebubbling, and we had more patients in the no glaucoma drainage device group which also needed a rebubbling. So I want to finish with a complex case again. This is a patient, again, after penetrating eye injury. She had a corneal scar, aneurysm, aphakia. She had developed secondary glaucoma the years after the trauma. Then she had several cyclophotocoagulations, and she showed up in our department in 2018 with an endothelial decompensation. We implanted first an artificial iris diaphragm, sclerofixated IOL. Then we performed DMAC after the first healing of this first surgery. There she needed 3 rebubblings. The cornea looked very nice. She had a good vision again. Then after 2 years, she had graft failure. We performed additional DMAC. She needed 3 rebubblings at that time. Then this was good for 3 years. Then again, decompensation, re-DMAC. But there she had a primary graft failure. We failed to have the graft attached despite the rebubblings. There was complete detachment of the graft. And then we decided to perform an endoart. After endoart, we needed 7 rebubblings at the end, fixation sutures, many fixation sutures to have the graft attached. You can see here this complex case. You can see the endoart here. Still here, the cornea is a bit thicker. We placed additional sutures, rebubblings, and then the cornea gradually, the thickness decreased over time. And but then we had the graft almost completely attached, but then she developed a fibrosis over the device, as you can see here, this thin reflection line, and this became thicker over time. And at that time, the cornea was quite thin, at least the part of the cornea which was anteriorly to the device. And then very recently, just removed the fibrosis, which is possible. Then the cornea in the center became clearer again. And so the cornea was, after removal of the fibrosis, still thinner, a bit thicker than it was before removing the fibrosis, but still the endoart is in place. So we are still looking at the patient, and we will see how the story will end. So in summary, disruption of blood aqueous barrier is associated with higher graft failure rates after DMAC. Very high graft failure rates come in patients with glaucoma drainage device. The novel endothelial keratopathesis endoart could become a game changer for high-risk eyes. There's no risk of graft rejection, of course. There are no cells. It's a very simple implantation technique. It's suitable for complex changes of the anterior segment with anterior synechia, artificial iris, or aphakia. There is a decrease in the corneal thickness and high-risk endothelial decompensation, but the question was, how far can we go? We can go quite far. We can adapt this in almost all of our patients, but you need to talk to the patient before that there will be quite a high number of additional surgeries after the main surgery. So you need the rebubblings, you need additional suturing, but this is something which takes quite time in these special group of patients. So thank you for your attention.
Bjorn, that's great. Sunita, you had a question, is that right? Or
Yeah, we have time for questions. So one question, Dr. Bachman, very nice presentation. And So what do you feel would be, do you think like Fuchs specifically, would that be an indication for this EndoR device? Because I think we have Professor Lionel Raj also, and we were a part of the phase 2 trial, both of us. And what we have seen, eventually what happens is that in the beginning it does well, but from the periphery you have some bit of epithelial hypertrophy which happens because there's excess of fluid in the periphery. So would you think like a case like a Fuchs where the peripheral endothelium is healthy, so you still maintain the balance, osmotic balance in the periphery, would that work better in these eyes compared to other indications as well? So what are your thoughts on that?
Yes, so since this device is more or less new also at our place, so we haven't dared yet to use this device in regular Fuchs patients because the diameter, as you said, is smaller, and usually you see this edema in the periphery or adjacent to the device, and it could work, but we haven't done yet. We don't have such a shortage of donor tissue, and the results of the DMAC are very, very good. And our experience with this group of low vision expectation patients is also that they, if they have the experience with DMAC before, most of them will tell us the vision was a bit better after DMAC than it was after EndoArt. However, they also acknowledge that they have stable situations once the device is working, and they are happy that they have something which might last for a much longer time, hopefully, than it would last after DMAC. So this is a true benefit, at least in this group of patients. So I cannot really tell how this works out in patients after Fuchs, but we have here an expert on this.
Thank you for the wonderful session and a nice presentation. I do agree what you said, and that is the very reason we always say when we go for endothelial keratoprosthesis, try to preserve as much as endothelium in the periphery. So the decimeter axis, try to have a maximum of 7 millimeters and not beyond. Otherwise, the peripheral cornea, this endothelial keratoprosthesis is just a barrier. It doesn't have an endothelial pump mechanism. So the peripheral corneal endothelium is very much essential. We shouldn't be sacrificing too much. Otherwise, we'll start having bullae in the periphery. Most often, we might have to do some punctures until it gets scarred or hypertrophied. So that is one important thing.
You would agree that this would apply to Fuchs, but not as much in the PBK anyways, we would have
Understand. I understand. So as much as possible.
Yeah.
So it's meaningful to have only 7 millimeters of descemeter rectus in the center. The device is only 6.5.
Yeah. Even Dr. Offer, what he conveyed is that some of the best outcomes probably would be failed DMAC, because you had some series of failed DMAC and failed PK, because where the periphery still maintains the corneal detergescence. So in the failed PK, I've done one. I think that was one of the best results I've got in EndoArt in the long term.
And can I ask about visual acuity compared to DMAC? Do you have a feel for that?
So as I said, some of the patients, they have the best feelings because they have the experience of the DMACs before and then the EndoArt. And some say their feeling is that the visual outcome is a bit worse than it was after DMAC. But the EndoArt is in a row of, let's say, 3 or 4 DMACs sometimes. So also the stroma becomes a bit worse with each procedure you perform, though they have swelling for a couple of months again before doing the procedure, the next DMAC, and then again edematous cornea for quite a while. So this makes also something to the stroma. That's my experience. So the stroma looks different if you have a short period of edema or whether you have a long period of edema. So it's really hard to have a good feeling the difference between EndoArt and DMAC on visual acuity in these patients.
Sumit, I just want to ask you, since you have also used the device, was your indication a little different? Because in India, we do have a lot of end-stage eyes,
So
wherein multiple PKs have been done.
yeah, so the study which was phase 2, and Dr. Lionel Raj was also a part of that, and that was a 1-year outcome. So that 1-year outcome is pretty good. But in the long term, like when we are following up those cases, we have this problem of periphery being, having that, and most of the indications in the phase 2 trial were all bad in the sense like they were not like very clean indications. They did have a good potential. The initial results are good, and that is why I feel, and I'm sure Professor also agrees, that it is where you have situations where the periphery of the, cornea is little healthier, is at least has some endothelial cells, might do better, because failed PK and failed DMAC, where you have periphery, sort of better. that kind of cases may have a little better indication. So I think we need some more data on that. But certainly the device may have good application in many of the conditions. And as what you pointed out, in in cases where you have glaucoma drainage devices where donor tissue is a limitation, and then it's not just the graft rejection, but the non-immunogenic causes of failure is also pretty much high because of the reasons you pointed out.
If I can just add very quick regarding the visual acuity, it was in our series, the baseline was 9 ETDRS characters, which by month 32 now is 44 plus characters. Quite reasonable for certain indications, yes.
Is it available?
It's not commercially available here. It has DCJ approval, but it's not commercially available.
Good. Bjorn,
Okay,
thank you
thank
so
you.
much. And now, so there's a talk I've been looking forward to all session now from Shigeru Kinoshita. And he is changing everything for us. And I don't think we will be worrying about the challenges in DMEC for too much longer.
Well, thank you so much, Bruce. And I don't think so, but I'd like to show some of our results or the experience, and that's cell therapy in clinics. Well, this is a financial disclosure to make, and several companies' name highlighted in block letters are relevant to this presentation. Well, Neutropendocel. So this is a name, the product name, the Biznova. That is about a couple of years ago, the Japanese Ministry of Health and Labor and Welfare approved this product as a regenerative medicine product for treating corneal endothelial failure. However, the last September, the government also sanctioned government-supported health insurance coverage for this product. In addition to that, newly established surgical fee for the transplantation of these cultured human corneal endothelial cells. So therefore, this transplantation was performed for just 24 cases of corneal endothelial failure at the 10 Eye Institute in Japan. That because in September, so the company only prepared for like 25 cases of that. So so that is why. So that this year we are supposed to have around 200 cases for this procedure. So how we do this? Preparation of this cell suspension just before the injection of these cells. These Biznova is coming as a 400 microliter suspension of the cultured cells. But before that, and we gently, I think, pipetting to make the single cell suspension and load it to the 1 millimeter syringe. And they are supposed to have the dead space-free syringe and 300 micro solution that is containing 10 to the 6 cultured endothelial cells with also the low kinase inhibitor. So this is a kind of picture. This is a pseudophakic bullous keratoplasty after the cataract surgery. So therefore, it's easy to remove the epithelial cell first to visualize the posterior surface. This is the small incision, and using the silicone needle, irrigation needle, and try to scratch the posterior surface of the cornea. Generally speaking, we try to polish the around 8 millimeter in diameter. We are not so sure whether the endothelial cell is still present or some of the extra matrix is there, but to try to clean up on the descemet membrane. And then using the vision blue staining and try to visualize, and then in our cases and in Japanese, so we do twice or 3 times just to make sure to clean up. And then stitches, a portion, maybe we do not need it, but because of the cell products is expensive, so just to make sure that there's no leakage. So anyway, and then inject the cultured endothelial cell. This is about 300 microliter. So try to collapse the anterior chamber, and then 300 microliter is a bit more. So increase the intraocular pressure, and then after that, and face down position for 3 hours. Face down position for 3 hours. Now that is a bit tedious way to do that, but based upon animal experiments, at least we may shorten up to 2 hours, but not 1 hour. So this is the, I'd like to show you three representative cases. This is the, in my hand, and pseudophakic bullous keratopathy, and I've already showed you in the video, pre-operative, and this is 3 months post-operative. So something like that, and 6 months post-operative, and he gained a 20/20 vision. Corneal epithelial cell epithelial edema is gone, and the endothelial cell density is about 2300 cells per square millimeter, and the corneal thickness come down to the within a normal range. This is 76-year-old male. So endothelial cell density is more like that 3 months post-operative, but still a coefficient of variation is large, but it is gradually, I think, with changing the arrangement. So this is a case 2, dissect graft failure. This is not by the graft endothelial rejection. This is just a chronic the failure of that. But there's no glaucoma operation episode. Pre-operative and 1 month post-operative, 3 months, and he got about 0.7 in corrected vision, and the corneal thickness also come down, although this is a dissect procedure, so therefore thickness is still 658 micron, something like that. So the case 3 is the PKP graft failure. I performed the femto PKP, I think about 10 years ago, and this is a pre-operative 0.07, and I performed, hopefully enough, now she got like a 20/20 vision on PKP, but when she received the COVID-19 vaccination, about 2 weeks later, she suddenly developed the endothelial rejection, and that is irreversible. So therefore, we asked for her to receive this procedure. So this is the 3 months post-operative. So I think, to me, the corneal thickness come down to within a normal range, but well, for instance, a repeated corneal graft, and we try not to do that, and I'm hesitant to do that. But the single injection of the cultured cells, and that could, I think, kind of reverse the corneal transparency. So, and also we understand, although we inject the allogenic cells, not the autologous cells. So you may argue about what about the endothelial rejection occurred after cell injection. But we also had some of the results. ELISpot assay against the interferon gamma confirmed that no antigen recognition occurred by the host. So when we inject the cell, allogenic cells into the anterior chamber, not only for anterior chamber associated immune deviation, but also antigen itself is very, very rare to recognize by the humans. So we published this paper in the scientific report about a couple of years ago. So we are safe enough to inject allogenic cells, and so far, in our experience, about 100 cases or so, there's no endothelial rejection occurred after the cell injection. So when we are talking about corneal endothelial dysfunction or the failure, in an Asian country, I think we are still dealing with the PBK, with the glaucoma BREB, or the corneal graft failure, not much of the Fuchs endothelial corneal dystrophy, pseudophakic bullous keratopathy after the cataract surgery, something like that. But the Caucasian European or the US people, they are mainly targeting the Fuchs endothelial corneal dystrophy for the treatment of the endothelial transplantation. Well, we are at least, we are aiming at the global standard medicine. So in Japan, using the 65 cases, and we performed phase 2 and phase 3 clinical trial. During that time, also, we prepared the cultured endothelial cells in a flask and shipped over to El Salvador. And then U.S. surgeon came down to the El Salvador and performed the 90 cases of this cell injection therapy. This is more like a repetition study, whether that is really working even in El Salvador. So they confirmed the result is right in our hands. So then after that, then the company named Orion Biotechnology made a lab in Boston, and then they performed the US and Canada phase 2 clinical trials, and that was I've heard successful. So and then they are thinking, they are planning to have the phase 3 clinical trial in a very near future. So I think I received this slide from the Orion. They had like 5 arms, very complicated because the FDA is different from the PMDA. So they use 3 different doses, and also low kinase inhibitor alone, and also the cell itself alone. So something like that. But the 1 times 10 to the 6 is the best result they received. So this is the Fuchs dystrophy, and then I injected cultured endothelial cells, pre-operative and post-operative. But at that time, we polished, not removed the Descemet's membrane. Probably the Japanese Fuchs endothelial dystrophy is not so severe as compared to US or the EU or the India or something like that. So, so there's some kind of argument. The polishing, do you think you could remove the gute? Yeah, well, I think we understand that. But in a clinical trial, we have to have one protocol, so just a polishing. So therefore, we did that. So the upper portion is the pre-operative, and two different kinds of the Fuchs dystrophy, I would say. And the polishing and the lower portion, the right-hand side, please see, almost all gute is gone, diminished. Although there's something in undermined Descemet's membrane. But the other portion, about half of the gute is gone, but still there are tons of the gute over there. So we published the one paper in the JAMA Ophthalmology last year. And please take a closer look at this. And this is the, that portion is the central part. This is the peripheral part. And you can see, and this is a kind of, I don't know. Well, that's okay. The kind of the border of the polishing, and then from the center to the mid periphery, you can easily see there's a most of the gute on the Descemet's membrane is already gone, but there are tons of the gute in the periphery, untouched area. So based upon the George Waring's EM picture many years ago, 1970, 80, something like that, and he divided it into 3 groups of the gute on the Descemet's membrane and in the Descemet's membrane and undermine the Descemet's membrane, something like that. At least on the Descemet's membrane, these gute can be removed, I think, based upon our clinical experience. So, but we could also perform the cell injection with the Descemet stripping only, very limited cases, but this is a case, and Fuchs dystrophy pre-surgery, and then 2 years post-surgery. So I think in the future, probably the many, I think, surgeons in the US, and they are willing to do that. So probably DSO with the cell injection, really depending upon the patient's situation. So I like this seeds and soil hypothesis. This is proposed for the cancer metastasis. But when we are thinking of the fate of corneal endothelial cells after the cell injection or endothelial transplantation, always that is dependent upon the seeds and soil. In this case, seeds is a quality of the cultured corneal endothelial cell. Soil is an anterior chamber microenvironment and also the disease of the corneal endothelial cells. For instance, soil, this is just a personal feeling. Good soil, I would say FECD, Fuchs dystrophy, or laser-induced bullous keratopathy, these are rather good. Moderate is the pseudophakic bullous keratopathy or the pseudoexfoliation syndrome related to bullous keratopathy. But bad soil is a multiple surgery related to bullous keratopathy or the glaucoma related to bullous keratopathy, something like that. So in this case, even though the seeds are okay or so-so, but still that product can be applicable to treat the good soil. However, we really want to treat the good, moderate, and the bad soil. So in this case, the quality is a key. So we always think quality of the cultured endothelial cell is a critical. So what future we have to do that? mass production and donor selection of the cultured endothelial cells, or storage and transportation for cultured endothelial cells. That we could freeze the, like with the DMSO, that could do it. That could do it, but but I think it's still the quality problem. There are some of the quality problem, but also the long-term maintenance of the cultured cell suspension. Now we can use up to 48 hours or something like that. But if we can prolong for about a week or so, everybody can use in a worldwide basis. So, and by manual technique, we have to think about that, and a triple procedure with a cataract surgery, or I think a transplantation with a DSO, something like that. So I think presumed benefit is a very few rejection, and also I would say that this is starting from the very young donor cornea. So that means rejuvenation of the posterior surface of the cornea, and also I would say safety procedure. So I think this is our group. Thank you very much for your kind attention.
Wow, Shigeru, what a great talk. And I'm so excited by all this. I really am. Because, well, it's you showed us there, it's so technically easy to do the operation of injecting the cells. It seems like something you could almost do even at the slit lamp. But my question for you at the moment, in 2025, many of us do not have access to the cultured cells. How about, what is your feeling about just trypsinizing the cells from a donor cornea, or even two donor corneas from the same patient, or different patients even, and splitting the cells down that way without, is it something we can do in a simple way locally?
I see. So I think the Jot Mehta in Singapore, he is trying to make such kind of things, and obtaining the rather higher senior age donor cornea or so, with a low corneal endothelial cell density, using the two donor cornea, and try to gather these endothelial cells not in culture, and then make the cell suspension, and then try to use these cells injected into the anterior chamber. That was partially successful, I would say, in an animal experiment, and he's about to start some of the clinical trial.
And Shigeru, how about cell lines? How about pluripotent stem cell cultures and endothelial-like cells rather than endothelial cells? It's interesting that you get no rejection with donor cells, but
yeah, well, I think there's one way, for instance, started from the iPS cells or something like that. But I think for us, we could generate cultured cells for 3,000 patients, started from one donor cornea. And then also we can freeze them, like passage 4, something like that. So now the government, Japanese government, accept only up to the passage 3. So this is more like a regulatory issues. Scientific, academic science, we could perform more than that. I think 3,000 started from the one donor cornea. I think that's we are quite confident about that. And then endothelial cell-like cells, I think I'm that's okay, but I have some of the fear about the some kind of adverse event, because these cells, they may easy to cover over the meshwork area or something like that. So that is more, I think, thinking about the adverse. So the quality, the mimic to the healthy corneal endothelial cells in vivo. So that's a way to do it. But this is just my beginning point, ours. So I think somebody will, I think, at least fix it, or some of the make some kind of progression.
Well,
Yes.
I'm already amazed that you can get enough for 3,000 operation from a single donor. I mean, we tried endothelial cell culture. This is quite a few years ago after we visited Nancy Joyce, and it was kind of witchcraft then. It was very difficult to do. Can you, without giving away any secrets,
Well-
Are you able to tell us the main things that you have changed that have made endothelial cell culture
Well,
easier?
Yeah, I think at least the use of the low kinase inhibitor. The continuous use of the low kinase inhibitor. That is the one way. And also the second is the a kind of donor selection. We used under the 25 years of age of the donor cornea, and I think teenager is better. But we still do not know the why they are so good as compared to the ordinal 30 years or the 40 years.
Right, interesting, really interesting, because we would all love to have access to the cells so we can do this.
Thank you.
If I may just ask one question to Professor. Very nice talk, and of course, we are looking forward to this therapy. The Rho kinase inhibitor in this therapy is only used per-operatively, where we inject it with the cells. The Rho kinase is injected with the cells. Post-operatively, do they have any role when the patient is in the post-op?
Well, I think theoretically, if we could use it, that would be ideal. But almost always, because of the clinical trial, we cannot use it. So that's why we avoid to use a low kinase inhibitor. So the PK, endothelial transplantation, cell injection, whatever, they are supposed to have some kind of endothelial defect somewhere at the very initial point. At that time, I think low kinase inhibitor has to be very effective.
Can one more question? Okay. Professor Kinoshita, you mentioned that some of the cases where you use a silicone tip to scrape off the Descemet's membrane, the Goutte had reduced. Now, do you think so? Because I think the whole premise of DSO is that you have to remove the Descemet's membrane. So if you can just, from stripping, you can probably just modify it to just scraping. Would that outcome be better with Rho kinase? Because the thing is, we know that the endothelial cells migrate much better on Descemet's membrane compared to on the stroma. So what is the need to really strip off the Descemet's membrane? Because if you're reducing the Goutte, probably that could be another alternative.
Yeah, that is really true. But I think before some kind of a treatment, DSO or the polishing, if we could detect that this Fuchs dystrophy, Goutte, can be removed by just polishing, but not this case. So based upon some of the fancy instrument or OCT or that or whatever, if we can divide it into two groups, and then I think you are right. So that's what I thought.
So Shigeru, with thanks, that leads us beautifully into our last talk of the session, which is also a really interesting topic, which is, do we have the AI tools to give us the disease classification that's going to answer your question?
Yeah, well, thank you so much.
This talk is by Dr. Praveen. He's not here, but he has sent a pre-recorded talk. So if you could have the pre-recorded talk. No, it's okay. It's the last session of the day. Yes, we should ask more questions. This needs to have a voice to it. There's a voice to it. Please play the audio as well.
And unfortunately, I'll only be reaching tonight. So Dr. Nidhi, as well as the rest of the speakers of EKLG, as well as members of EKLG, have kindly agreed to me doing the recorded talk. So the topic of my presentation today is going to be about being able to predict the outcomes of endothelial keratoplasty. But before we actually start speaking about the outcomes, I'll take a couple of minutes about why is it important to be able to predict the outcomes of endothelial keratoplasty. So I come from LV Prasad Eye Institute at Hyderabad, and the cornea service at LVPI is called the Shantilal Sangvi Cornea Institute. And we do see a number of different disorders in the clinic. And amongst the disorders that we see in the clinic, on an average, about 150,000 patients in a year. The least common actually are patients who come in with endothelial disease. So, in fact, endothelial disorders forms about 3% of all patients who come into the clinic, whereas ocular surface, infection, inflammation are the majority. So why are we still talking about a model that will predict the outcomes of patients who have surgery for endothelial disorders? The reason is, though they're rare, the number of patients with endothelial disorders that require surgical intervention is very high. Almost everybody requires a surgical intervention. And amongst the approximately 4,000 patients with endothelial disease whom we saw last year, close to 50% of them are those who had post cataract surgery, corneal edema. Then about 30% were patients who had corneal edema with no known etiology. About 16% were endothelial dystrophy, large majority obviously being Fuchs, or 8% were graft failure. And I was just talking to you about the need for endothelial disorders to be treated surgically. And we just completed about 50,000 corneal transplants somewhere about last year. And of the patients who undergo corneal transplants at our institute, endothelial disorders is the second most common reason why we've done transplants in the last several years. These are 5-year blocks. And in the current data that we have of patients who are undergoing endothelial keratoplasty, EK, which is a combination of DSEC and DMEC, is the most common type of keratoplasty that is being done, which is the reason why it is important to be able to predict the outcome of this surgery. At this point of time, when you speak to a patient about predicting the outcome of surgery, we only are able to quote numbers from small published articles, majority of which actually are not Indianized nor Asianized. A lot of them are eyes from Caucasian data, so it might not be as accurate. Mainly because the distribution of the pathology that we deal with in India and in Asia also is very different from the pathology that we probably will have in other countries. Give me a second. Amma. So, sorry, I'm having a little bit of disturbance in the OR, but so what we did with our data of all our corneal transplants was we took all our data and we put it into a database. Almost 30,000 surgeries went into creating this online database. And we looked at several parameters. And in fact, some of the parameters we looked at was also distance. And interestingly, about half the patients that we deal with have to travel more than 200 kilometers to the hospital. And about half of these patients are located in rural or semi-rural areas. This is probably very different from the Western literature as well as the distribution of patients where access is not so much of a problem and where the type of disease for which endothelial keratoplasties are done are very different as well, the majority being Fuchs. Now, this is important because the ability of patients to follow up is also diminished by distance. And this is shown in this particular graph where it's seen that about half of the patients who undergo surgery at LVP don't follow up at the end of 1 year. This may not be very critical from the point of view of endothelial keratoplasty because you don't have sutures to deal with. But in general, lack of follow-up also means lack of compliance to medication. And it has been shown that not using steroids long-term has a much higher risk of rejection in these patients. And this is the reason why follow-up compliance is not very important. So what we did initially is we actually built an AI/ML model for predicting the outcomes of keratoplasty, not just endothelial keratoplasty. And what we tried to do here is we tried to see if we can predict which graft is likely not to do well after surgery, who is the most likely to miss a follow-up visit after surgery, where do these people who miss their visits come from, and would also help with pre-surgical decision making. So as part of this model building, we were able to get about a 75% accuracy in the prediction of visual acuity, and we were able to get about an 80% accuracy in being able to predict who would be compliant to follow. We also were able to get very good survival prediction curves, and these were relatively accurate in the first 12 months with about close to 75 to 76% accuracy. What we've done with this is we've converted this into a mobile application, and this will be available for use by physicians across the country, colon transplant surgeons, as a mobile app, and hopefully by the end of the year we'll be able to have this released and available for use. Following on that, we also tried to build a predictive model for endothelial keratoplasty. And here we've tried to predict the post-surgical best-corrected visual acuity and to also to forecast the expected graft survival rate for EK procedures. So we used several different models to actually build this predictive algorithm. I won't go through the details of this, but then the overview of the data set was about 9,400 procedures went into building this data set. And this was around 8,000 patients, and about 3/4 of these procedures were completed in the last 8 years. So it's more recent data. And we also have data going back as long as 18 years, because that's when we first started doing DSEC surgery. And following beyond 3 years, the post-op follow-up data was relatively sparse, only about 15%, as you can see in the graph as well. Even distribution between males and females. More of our patients were about 2/3 were patients who paid for their care, about 1/3 were from the lower socioeconomic strata, about 40% urban patients, and like I said earlier, about 55% of our patients resided more than 200 kilometers away from the surgical center. About 3/4 of our patients are over 50 years of age. So the preoperative best-corrected visual acuity, about 74% of patients had very poor vision, that is vision less than 2400, which is very different from what you would see in data from Fuchs patients, because these are mainly post-cataract surgery called edema. And like you see, the top indication, 62% of our cases were because of post-surgical corneal edema, and only 6% were Fuchs dystrophy. Of the types of surgeries, we started doing DMAC from about 2017. So overall, about 78% of our cases are actually DSAEK, 11% DSEK before we used automated tissue prep, and about 11% of them are DMAC overall. But now, since 2018, about 20% of our cases are DMAC annually. Additionally, we had a couple of other surgeries, IOS exchange and cataract surgery being the primary surgeries that were done in conjunction. So the features of the model were, we selected demographic, clinical, and surgical features, and a few post-op features as well. So the demographic features are fairly commonly collected by all hospital systems. Clinical features, we picked best-corrected visual acuity, the indications for surgery, any comorbid conditions, and any other surgical conditions that were done. For surgical features, we picked the type of surgeon, experience, the diameter of the graft, the donor parameters as well. So when we looked at the number of surgeries that we did based on year, we had about 1,000 endothelial keratoplasties done every year. And with time, you can see that DMAC has become a little more popular, but because of the kind of patients we have, DSEC still is the predominant endothelial keratoplasty we do. The best corrected visual acuity outcomes for DSEC were relatively poor. About 1/3 of patients didn't have improvement in visual acuity as compared to DMAC. That again is because of the very challenging eyes that we do DSEC in. The patients with Fuchs had very good outcomes as expected, whereas the patients with either sort of a corneal edema or failed PKs didn't have very good outcomes as you would anticipate. So the visual acuity outcome prediction model that we used, where we had only pre-op data, had an accuracy of about 72% in predicting the visual outcome post-surgery. And if you use the first month post-op data, had about 83% accuracy in being able to predict future visual acuity as well. This is the area under the curve, the ROC curves for both models with pre-op as well as pre-op and post-op data. And you can see that the one that has both pre-op and post-op data has a little better accuracy in prediction. And we will also be able to predict the graft survival relatively accurately. In about 80%, it is aligned with the prediction of the graft survival with some amount of standard deviation as well. So to summarize, what we had was we found that Fuchs dystrophy followed by post-surgical chondroderma had the best outcomes as expected. Failed grafts are the indication that had higher poor and very poor outcomes. More than 50% didn't do very well. About 28% of failed grafts showed no improvement in vision. 60% of cases overall showed an improvement in best corrected visual acuity, and about a third remained the same. So about the AI model itself, the pre-op model has about 72% accuracy in predicting post-op visual acuity. The post-op model that includes one visit post-op has about an 83% accuracy and is about 82% accurate in predicting graft survival post-op. The initial results are very encouraging for forecasting and decision making, and you can actually now tell your patient with more confidence how their grafts will do. But in the future, we hope to increase the number of features and also refine the existing features to make it more accurate. And hopefully, this is something that we'll share with all of you in the future as well. Thank you very much for your patience. And sorry again for not being there in person, but hopefully, I'll see you tomorrow at the meeting. Thank you.
Good. Well, we are a little over time, so I think we should restrict the questioning a little bit for the last talk, particularly since we don't have the speaker here. Just to say, I mean, that's an interesting extension of what we have done with registry studies before, using the tabular data and machine learning modeling to make predictions for prognoses that help us to counsel our patients accurately. And what I would say is try and take an interest in the whole field of AI modeling and deep learning if you can, because it's going to have an immense impact on your medical careers going forwards. And it's so interesting as well, it really is. So, Nidhi, I'd just like to finish by thanking you again for your incredible energy in organizing the whole group and everything. I think that deserves a round of applause, right? So you've done a really lovely thing here, and long may it continue. And it's a pleasure and a privilege to do a small part to help you in that. Okay.
I would just like to thank everyone, the entire EKLG team as well. I'm not alone. I guess we have a very strong team. We have 8 scientific members, and we do have Aditya here. Aditya, thanks for being with us since the beginning. He has been the core member since the beginning. And also all the speakers here, you have been there for EKLG as masters, and since last 5 years, we've been standing really, really strong because of all of you, and to all the audience and the learners who have sent so many emails, messages for us. Let's just stand for a photograph. I would like to invite all of you also for the photograph here, please. It's nice to have all of you here for the photograph. Take a photo from the phone as well. Please come here. I'd like to have all of you here.
This is a very nice place.
We have such a